Good afternoon, everyone. Thank you for joining us. This is our second in our series of webinars specifically for our rural health clinic folks. We are joined today by Carrie with Wintergreen. While Carrie and we were chatting before, I don't believe we've ever met in person, but I have heard through the grapevine that Carrie is one of the best in her field in terms of revenue cycle management. And so today she is going to be sharing tips and ways of building front-end competencies and improving our revenue cycle management. Again, we are a smaller group. If you have any questions, feel free to unmute your line or put something in the chat. I'll be watching the chat. If you're watching the recording and you have any questions, concerns, more information, please feel free to reach out to me. And with that said, Carrie, I'll turn it over to you.
All right, great. And thank you for that introduction. So I appreciate it. It was very flattering. My name is Carrie Bova. I have 15, maybe many more now. It's kind of like turning 30 as a woman. We're keeping it at 15 years of experience. And I specialize very specifically in rural healthcare billing, revenue cycle management, and really identify growth opportunities to get your organization to the top, basically, and to be recognized as one of the top 100s. I'm hoping that's one of the things I always aim to achieve with any facility that I work with. Today, we're going to really specifically focus on improving revenue by generating revenue by building some front-end competencies. And I know there's a lot to go over, so please, again, do not hesitate to ask questions. If you're not comfortable asking questions during the presentation, my email will be included, and I'm always here as a phone a friend to ask for more detail on some of the topics that we'll be presenting today. So very specifically, and I feel like there may be a little lag here, so I apologize. We really have seen, and I know we've heard for many years, that patient access is critical. We've been hearing this from the National Institute of Rural Health. We've been hearing this from HFMA, AHAM, and different organizations. But patient access staff are not fully aware of the impact their role has on a revenue cycle department. They're really instrumental in reducing expenses, improving patient retention, ensuring timely claim payment, and customer satisfaction. I have seen this really work and generate significant improvements in revenue. Patient access has a high turnover and rate and staffing challenges. And I think a lot of that is relative to an incomplete understanding of their role, or inadequate training and or continued education. So many revenue assessments that I do, we go in and people get 2 to 3 days of training, and then they're sitting and they're patient facing, and they may not fully understand the components associated with their job. So some of the best practices in patient access include ensuring the integrity of the data collected and making sure that they have a great understanding of insurance and eligibility, but not only just eligibility understanding, but how that affects current benefits, services. They really work very well if you develop patient access, acquisition of referrals and authorization information, medical necessity validation, and collection of patient financial liability to ensure compliance. So observations that from a patient perspective, I really want us to step outside of what we do in our organizations and really start looking at our reception or registration areas from a patient perspective. Do they appear organized and efficient? Are the processes timely and efficient? I have received many complaints over multiple organizations that it's too timely, it's too manual, paper driven. Are your staff friendly and knowledgeable? The initial impression that patients get when they walk into our organization, specifically rural health clinics, if any of those aren't favorable, it can really affect your entire revenue cycle, and it can lead to a number of ongoing issues. And most importantly, those issues could result in loss of patient empanelment or failure to maintain patient bases in our organization. So any patient registration process is instrumental in making a good first impression of your organization. Building some of those onboarding processes to make sure that your departments are making an immediate and pleasant impression on your patients is critical. Patients prefer short wait times and simple tasks that do not require multiple steps or complicated paperwork. A lot of folks, specifically in rural healthcare, aren't always using Topaz for patient signature. So some of the impacts of not really building front-end competencies will be loss of patient retention, significant claim rejections or denials. And I know that if there is any CFO or VP revenue cycle manager on these webinars, they will tell you that some of the information that's always presented up to them is there were so many registration errors that are a result in delayed payment or denial. Increased or additional expense for lack of pre-service or point of service collection. We'll go into that in a little more detail. Again, increased or additional expenses related to the incorrect coordination of benefits and understanding. There are very significant compliance issues related to balance billing. They are being identified on the OIG reporting federally. Almost every report that is published is coming out with some balance billing issues. We have to be extremely cognizant of that given the new No Surprises Act and pricing transparency compliance. And we also see that, failure to really develop these front end processes can cause increased days in accounts receivable. And what we can do is improve. So we should always focus on patient retention as a priority. Patient retention in this evolving networking where we're seeing that people can go to the doctor on their phone. It's really important to remember that patient satisfaction efforts begin with their initial experience, and that is typically always through patient access. The perception of every encounter at your organization is really critical to continued patient engagement and service. So just some, I call them basic tips. Ensure that your areas are clean and free from off-putting personal effects. I had one Press Ganey survey at an organization that said it looked like a bingo desk at the registration because there were all kind of personal effects. So really making sure you're looking at that. Make sure your patient access representatives are dressed for success. That they're friendly and courteous and they're presenting that. I always tell everyone to think of the Disney model. You want everybody smiling, happy, ready to be there to support you. Really look at reducing and automating paperwork for more patient-friendly experiences, electronic signature pads, employee self-check-in kiosks if able. A lot of those have become very helpful. We've seen organizations begin using those and it really eliminates the labor lift as well. Really working on scripting your patient communications to ensure the delivery of your organization's message is not misinterpreted, that it's standardized and it's clear to your expectations of your mission. Establish follow-up communications or random internal audits to determine patient satisfaction and do a quality assurance process. And create registration per encounter stats and expectations. And what I kind of mean by that is how many minutes do you expect a registration to be completed in? What are the core elements like verification of eligibility, things of that nature that you expect to be seen, and really communicate that with the front end staff, but communicate the why. I think a lot of times patient access staff is not always recognized for how critical their role is, and really get them to have some buy-in, improve employee satisfaction. Well, it will definitely reduce turnover rates. We've seen that happen. Telephone etiquette. I think that now as we move, we saw the pandemic drive a lot more telephone encounters. We saw a lot more things being performed virtually in services or follow-up, we really need to start looking at that as a access point and ensure that all of our patient encounters are handled in a professional, efficient, and courteous manner, conveying that image of friendly and knowledgeable staff, even with the telephone encounters. Simple things that often come again on these surveys that we see are calls just ring and ring and ring. We should make sure that we have a process where all of our calls are answered within 3 rings. Call transfers should be warm handoffs to ensure that no drop calls, noise, etc. So I'm calling Laura. I'm going to say, hi, Laura, I have Mrs. Jones on the phone. She's calling for this. When I hang up, you will have her. Making sure that you're really going the extra mile to make sure your patient is satisfied and connected appropriately. Don't leave patients on hold for extended periods of time. Routinely check in and explain to the patient if there's a departmental delay. Don't leave them out there listening to the music forever, wondering if anyone's ever going to get back or if they should hang up and recall. That creates lift on your organization that's unnecessary. And then really working towards establishing patient callback protocols to ensure timely and effective management of your patient needs. Also to identify there's no missed opportunities in revenue. Sometimes patients are calling, looking to establish at your practices, they're looking for a service that they need to have done, and really not following up, you're leading yourself into the risk of losing that patient that could potentially be a future impaneled patient that generates multiple avenues of revenue for you. So scheduling and maintaining appointment guidelines. I think this is very significant in the industry. It has been recently being discussed at the payer level, at the legislative level. Most payer contracts, if you don't know, have appointment guidelines built into them if you're participating providers. So, and they are doing secret shopping. So ensure your processes for scheduling allow for timely and compliant scheduling. You should consider patient self-scheduling options through your website if that's possible. It can reduce lift on existing workflow for elective services. You can schedule appointments in consecutive blocks and collaborate to ensure efficiencies for the patient. So for example, if the patient is coming in for diabetic education as well as an office visit, make that patient experience concurrent and really allow for that patient to have one episode. Ensure that your organization has an appointment reminder system. So basically make sure that that isn't 5 days prior to the encounter, because in 5 days, a lot of our patients can still forget. They can be automated phone calls, automated messaging, but really looking at establishing reminder protocols. Use some wait listing. I know a lot of places may already do that, but use wait listing to mitigate late cancellations and no-shows. Consider telehealth versus in-person care if applicable and appropriate. And some of that can be for those no-shows, have your nurses following up, etc. Collect data and ensure verification of information no more than 48 hours in advance of a procedure. That is very important, especially because a lot can change if we're verifying 2 weeks prior or only at the time of scheduling, and it's been quite some time. So really creating that data validation within 48 hours. And then I do recommend, if you have a consistent appointment vacancy problem, like no-shows, late cancellations, explore double booking. Do it very cautiously and very strategically, but a lot of organizations that I know are using a frequent no-show flag in their EMR. So they know if a patient has a frequent no-show, it's probably appropriate to double book that encounter, because at least then you're not losing it. But again, be very cautious and strategic, because it can have a counter effect of people not being seen timely. And then implement work lists to ensure capture of all add-on patients, et cetera, for data reconciliation and accuracy. Sometimes a nurse will throw someone on a schedule and you think you have validated everything through your patient access department, but that appointment was missed and maybe has some inaccurate information. I think it's very important to just really make sure you have a work list to identify patients coming in the next day and that you have accurate information. So we talked a little bit about appointment guidelines. Again, I want to highlight that we are being told that there are mystery shoppers that are contacting providers to determine if they are meeting the appointment guidelines defined in the provider manuals. Here is just a sample appointment guideline from Centene. And it basically says if you are a primary care provider, you have to fulfill routine requests within 30 days of request, specialty care within 21 days. Referrals have to come in within 5 days of request, just different things of that nature. And if we are seeing that we are not, if there's a mystery shopper and it's not, we are seeing that there is significant complications with provider enrollment and with contract guidelines. They are specifically, I know that some Centene organizations say they will cancel contracts if we can't meet the patient needs. That being said, in rural healthcare, we know we have provider shortages, recruitment issues, et cetera. So really finding a way to make sure you're aware of the appointment guidelines for every payer and that you're meeting the expectation or at least documenting that you've added a patient to a wait list for the next available appointment due to extenuating circumstances. Patient reminders. So again, establishing those patient reminder protocols to mitigate no-show appointments, create a wait list or a bump list to fill in cancellations. I recommend creating a daily opening list for appointment slots available and communicate that to your scheduling departments if you have them or whoever is responsible for scheduling. A lot of folks in critical access hospitals with rural health clinics are communicating that now daily with their emergency department. So if a patient comes in after an appropriate medical screening and their care could be provided in their on-campus RHC or at the RHC to eliminate long ER wait times, we do see that is becoming an effective trend. Automate manual reminder calls should occur at 5 days prior to a scheduled service. And again, the day prior. Again, these are best practice recommendations. Confirmation of appointments or cancels within the 5-day window can allow for the patient from a wait list to be contacted and given an earlier opportunity. Again, helps to meet those appointment guidelines, and it creates a revenue source for an otherwise loss if someone cancels. If a patient cancels the day prior, automatically reschedule the patient and let them know that. Create a nurse call list for no-shows to determine if care management minutes or virtual telephone encounter claims can be generated. Establish patient appointment protocols if you have not done so already, and ensure that patients sign an appointment attestation at least once annually. If you do that, you are effectively able to establish no-show policy and bill no-show visits accordingly, so you do not have total loss for those visits. Pre-service and point of service collections. This is a very important expense reduction for your organization. Appropriate and accurate verification of out-of-pocket expenses being collected at the time of scheduling or at the time of check-in. It significantly can decrease the costs associated with collecting patient balances while also improving uncompensated care at your organization, prevention of bad debt. There's so many benefits. A lot of folks and organizations use an early out vendor. If you can not send each encounter to an early out vendor and look at your cost to collect, you could be saving up to $10 per encounter by an expense reduction just by collecting co-payments. So develop scripting and signage to display your position to your patients in a friendly manner. Again, how would you like to pay today? Not, make the scripting standardized. Don't let it be subject to interpretation. Develop analytics for what should have been received in point of service collection versus what was, and then kind of monitor for improvement. We've had a lot of organizations make that like a fun thing where the organization is providing a luncheon for the department that gains the most point of service collection or has the highest rate of improvement, et cetera. And then develop a follow-up work list. A lot of times we see this being driven to financial counseling for patients whom were unable to pay at the time of service. And really, if you develop that work list, it's either going to get you enhanced collection rate, again, kind of mitigating that cost to collect, or effective management of charity applications to collect balances prior to billing and within the charge lag day parameters. Typically that's 5. So, your DNFB day should be 5. So if that is the case and you have financial counseling, look at having the financial counselors make contact with everyone that had a copayment due, that was not able to pay, establish a communication platform for that. Pre-registration process should really accomplish improved registration in-person times with better patient flow, a decreased expense to collect patient liability, and a higher quality patient experience that can improve patient retention. So pre-registration occurring prior to the visit, it should allow for the collection of all that basic data that takes so much time when the patient's sitting in front of you. For demographics, it really introduces a registration time where we know industry-wide it should be less than 8 minutes per outpatient encounter, right? We're seeing that with pre-registration, we're getting 3 to 4 minutes to department, and that is important and it improves the flow. Incorporate scripting in pre-registration for that out-of-pocket liability, again, prior to the patient arriving. Consider mailed questionnaires for new patients that could maybe be returned, or even existing patients, or direct software pre-registration. A lot of EMRs allow for your patients to create a lot of pre-registered information. Again, telephone in-person options for pre-registration, really meeting the patients and saying, we're going to get you in on the day you arrive as quickly as possible. But also look at creating cross-functional workflows for collaborating facilities and campus locations. And what I mean by that is, for example, if you're an RHC and the patient is going over to have a radiology procedure, should that patient have to completely re-register? Could you do that at a checkout process so your patient can go directly from the department or from one department to another without having to have multiple duplicate registrations? That is something that you should explore, again, to just improve the convenience to the patient. For registration, I think that it's really important that we look at what we're doing at the registration window, obtain and validate patient demographic and emergency contact information. So many patients tell me all they ever get asked is, everything still the same or has anything changed? We really shouldn't be doing that. The role is really a validation of data accuracy, so making sure that's appropriate. Some little tips of identifying the reason for visit. And that also includes identifying the correct third-party liability and necessary form. So if we were looking at an accident or a compensation injury, if there has to be an assignment of benefits for a automobile accident, if there has to be a third-party liability form because of an accident, there are things that we really need to make sure our patient access staff are aware of. Always obtain accurate insurance and payment information, and make sure that the input is in the correct and respective order. So many registrations focus only on the primary insurance and not all insurances. Again, if we have not obtained a copayment or coinsurance, we know how to script for that and make sure we're collecting that to reduce expense. And then make sure we're obtaining and maintaining appropriate signatures for treatment and release of information, and any of those described needs that we have to be compliant within the registration process, like notice of privacy practices. Our organization should be giving surprise billing disclosures at our RHCs. So we should be making sure those are on file, specific to the new regulations. Now, the next area is really important to me because I have seen this have significant revenue growth for critical access hospitals and RHCs in combination of collaborative workflows. This is an extremely significant revenue opportunity that everyone, if you pay attention to nothing else in this presentation, please pay attention to this. The identification of preventative service needs. Medicare includes information relating to the eligibility of preventative services. You can use Medicare both for traditional and for your Medicare Advantage enrollees. I don't know that everyone always understands that. Many managed care plans also provide reports, a lot of the Medicaid managed care plans, for patients that are impaneled to your practice or your provider with preventative service or other service needs. I recommend everyone start with your Medicare patients and find a means in which, and I'll show you in the next slides, to communicate the preventative service eligibility either to the nursing staff or to the provider. It's important to note that if you have care management, coordination of these services can count as care management minutes and get you that $77.94 per month. You can also reach out to your managed care payer representatives and establish routine delivery and accountability for monitoring your patient empanelment for what services the health plans are expecting them to do. Anything from chlamydia screening for adolescents to there's lots of opportunity, and a lot of the payers already maintain these reports. Establish routine reports and assignments to generate revenue for your practice and organization. And the tip of this is look at your patient schedules for the next week and look for patients whom are eligible for Medicare. Run preventative service eligibility and communicate that. You can realize up to $2,000 on average in ancillary revenue per patient. And the most important thing here is preventative services have no out-of-pocket liability for our patients in most scenarios. So this is critical and important. And this is just a sample. In reviewing one patient, 6 pages. So you go out to whatever your national government or CMS platform is, there's a little tab that says preventative service. These are pretty standard with First Coast, NGS, just different platforms. But basically, as soon as you do that, this one showed one patient had 6 pages of eligible preventative service needs, and they equated to $3,166.81 in reimbursement should the patient receive all of these services eligible. That's one patient. So when we start looking at what this is, again, here are some of the preventative services. Here are the eligibility date. There's a lot more information. I apologize, I clipped it to exclude PHI, but basically cervical cancer screening, lipoprotein, all of these things. And then here is the quality management of the patient, but these are the actual fee schedules for this patient's jurisdiction that would have generated the ancillary revenue. So when we start looking at preventative service eligibility and building that into front-end processes, just for a moment, imagine a practice with 100 active Medicare patients, even eligible for half of the preventative services indicated. There's a potential revenue gain, again, not directly at the clinic, but indirectly at the critical access hospital or other ancillary departments, $20,000 per 100 patients. That is unbelievable numbers that you're generating revenue from an existing empanelment. You're not out searching for it. So really pay attention to that. And if anyone has any questions or would like to review that in more detail specifically, please feel free to reach out. Coordination of benefits. This is a huge issue from a patient accounting perspective, and it's usually the finger pointing back to patient access. Really looking at applying coordination of benefits to anybody that has multiple insurance plans. And in this slide, I've just gone over a few things, like I'm not sure if everyone knows, but potentially a child that's covered by both parents. Insurance companies use the birthday rule to decide primary coverage for dependents. Most often, it affects children, but it can affect others, other disabled individuals, et cetera. It's important to note that the subscriber whose birthday month and day fall first in the calendar year are always the primary coverage. And I know, many patient access departments have said, well, the mom says this, the dad says this. That's the whole intent of this rule we do not, as facilities, get involved in personal, matters of custody and payment, et cetera. This is the rule. The birthday rule establishes that the parent with the month and day first is the primary coverage. That is just the rule. So if there's anything that you have in your organization, please pay very close attention to that and feel free to look up. One of the other things that is frequently noticed is Medicare beneficiary hospice rules. Sometimes patients are eligible for hospice based on a chronic, very terrible terminal condition, but they still come to see their doctor for other managements in our clinics. And it's really important to identify that it's clearly defined and communicated for services that are non-hospice. So it's a modifier that has to be appended by coding, but communicating, a patient enrolled in hospice, however, service is unrelated to hospice, is very simple and can prevent denial. Medicare secondary payer questionnaire. I think there's a lot of confusion sometimes with Medicare benefits and how they relate to being covered under a spouse and who's primary. Completing the MSPQ is critical in finding the proper insurance coverage order. So please take a look at that. And then workers' compensation. This is another real huge, a lot of places outsource compensation, and I understand that. But a lot of times by the time that's returned for some of this information, the claim is outside the filing limits. So workers' compensation coverage is really limited to the covered diagnosis for the compensation claim, ensuring that we have correct information relating to the injury and the covered diagnosis is critical to prompt payment or to the appropriate payer selection. So just make sure that you have a process in place to confirm the covered diagnosis and treatment for the injury. Again, a lot of folks outsource workers' compensation billing, and we have a lot of folks that present with workers' compensation, but really make sure that we are only treating covered diagnoses and not, everything. If the patient has back pain, but it was a shoulder injury, it's not going to be covered by the compensation claim. The other really important thing is understanding that Medicaid is always a payer of last resort. Much like Medicare, most Medicaid plans have information relating to coordination of benefits. Accounts must be registered accurately with the correct order. Sometimes Medicaid systems are not updated or updated timely. Other health insurance is identified as primary. That would make Medicaid the secondary payer. Billers can adjust that through appropriate remark and remittance codes, but we have to have the correct insurance order to be communicated based on the eligibility response. Financial clearance. Financial clearance is really indicative of the likelihood that we're going to receive payments for the services that we have rendered. So the patient access role really has a large portion of financial clearance burden. The benefit determination. A lot of times, and this is very important, services that we are rendering in our organization may have different coverage. And I'm thinking very specifically about behavioral health. We have third-party administrators to certain payer contracts. We have certain services that are not covered under a patient certificate of coverage, and we need to identify that to the patient prior to them receiving services. So really understanding eligibility and benefit detail is really important to invest in that education for our patient access staff and make sure they have a comprehensive understanding. I know a lot of folks are going to, make sure they brutally hate this part, but advanced beneficiary notices, medical necessity components, like we at Patient Access should be delivering ABNs. A lot of times they're delivered at the department level. It can happen, but we need to make sure that scripting is supplied to not dissuade patients from receiving an exam. I have found that patient access departments that effectively manage ABN issuance and medical necessity requirements have reduced the medical necessity denials by 38%. That's significant. That's significant money that you're getting back to your organization. And cash realization is much timelier than those who later query provider offices, handle it at the department and the coding level. So consider medical necessity review process daily for any incoming orders, and collaborate with referring and servicing departments to make sure that anything that does not meet medical necessity is addressed prior to billing rather than post the service delivery. Other little really important and beneficiary notices are on the OIG work plan. So just sending that out there, but really making sure that we have processes in place where we have the important message from Medicare. We have the Moon notice, HIN notices. They should be easily accessible. Sometimes those are handled in utilization departments, review departments, but looking at how patient access can be the second look and really quantifying and qualifying that encounter to make sure we're appropriately paid and mitigate any revenue risk. Authorization is a payer requirement. It is continually legislatively being addressed. I agree with every organization that said this is just one more thing for rural healthcare, but it's a thing that we can't ignore until changes happen legislatively. We have to be looking at this. The payer requirements change frequently, sometimes 30 to 60 days, we have updated authorization grids. So really establishing protocols, not only to obtain the authorization, but again, reconcile authorization post-service. And the reason I say this is it can save thousands in lost revenue. And I'm going to use a radiology department, for example, CTs. Oftentimes a CT with contrast is ordered, but maybe later it's changed to CT with and without, creating a scheduling reconciliation process where they are looking at the prior day's delivered CT services and confirming that the service delivered meets and mirrors the authorization and the appropriate code, because within 24 hours, if it's identified to the health plan, you can in fact update the authorization and have full coverage of those services. So that's very important. Referral management. This is another way to really communicate and enhance ancillary payment. Establish those preventative service communications but while you're doing that, you're also meeting value-based care requirements that will lead into ICD-11 and many other components in the future. Communicate that with your nursing or provider staff to ensure that preventative eligibility for your empanelment is addressed and ordered. Review payer-based non-compliance reports and schedule patients accordingly for those testing or follow-up adolescent well childs, et cetera. And then educate on your system service offerings to your patient access staff and encourage scheduling through your system. Really, again, mitigating that here's a physician order, go wherever you want. And we'll talk a little bit more about this with the checkout process slide, but really developing a checkout process where you're defining that patient going to your ancillary or your critical access hospital that you're a part of, really can help encourage revenue. And again, making that checkout process another opportunity if you're doing any care management or you're thinking about it. It's really a place to identify referral management, have a checkout process, get the patients registered to where they're going next, ensure that they're using services within your system. So really looking at having a checkout protocol, again, to improve patient compliance with ordered services, and then their experience with order services really driving that revenue to your organization can have a significant budgetary impact. consider registering patients or registration of patients at checkout to facilitate a more patient-friendly process and get them on the schedules immediately. So looking at how that role can maybe be expanded if you're using multiple EMRs, et cetera. And then use them as a means to provide charity care applications, financial counseling on outstanding balances, payment plans, et cetera. Patients feel well informed. Make sure it's a checkout private place. But sometimes they can say, oh, wait a minute, somebody didn't get my AARP. So you're really able to kind of eliminate before your patient leaves and you're trying to connect with them through other means. Before that patient leaves your practice, you're establishing a second check to make sure all your information is correct and really driving them to utilize services. And that does help generate more visits based on those testing being completed to come back and follow up in your RHC. So it really can be a volume driver for your RHCs as well. Financial counseling. Financial counselors really were created to assist patients in understanding their insurance coverage and benefits and how they will apply to the services that they're receiving. But we're seeing that those roles and expectations have significantly increased since the implementation of the pricing transparency regulations, the shopping for services, patient estimates, et cetera. So really a couple of really quick pickups that we've identified in some pilot programs is a 90-day look back. We created reports where often we're able to identify patients that were registered with self-pay or with Medicare primary that are now potentially dual eligible based on facilitated enrollment, et cetera. Doing a 90-day look back and rechecking their eligibility with Medicaid plans is really helpful. The other real identified issue that we find is many times if a patient is registered with a Medicaid managed plan, they have a traditional Medicaid coverage for up to 90 days prior that is not often identified because we show eligibility. They say, I have Fidelis, but we're not checking the 90 days prior when we identify maybe a patient has Fidelis or a United Healthcare Community Plan. Their application with the state for Medicaid benefits sometimes allows for them to have that 90-day look back. So really implementing those processes to establish a payment source and really be compliant so you're not balance billing any patients for a self-pay bill when they were eligible for Medicaid. That's a huge no-no from a compliance standpoint. So taking a look at that. The other thing we see financial counselors do, and very effectively, I've seen this put in place, is patient access staff are doing the bad debt audit and they're obtaining all the information. And what that really helps with is it ensures the Medicare bad debt write-off processes are built in and that you're realizing that bad debt review in a compliant manner and more so on your cost report. The other real benefit of this, and I'm happy to share if anyone wants this, please, reach out to me. The email will be there. I have a template for the bad debt policy with the 2020 changes, the audit, and basically what we utilize to really fill out that S10 worksheet to eliminate the lift and the cost associated with that for your facility for cost report. So please feel free to reach out on that. But this is a good place. Financial counseling is a good place to have this. And it does improve the realization of bad debt and reduction of bad debt that's sitting out there unnecessarily that can be claimed on your cost report, which does in fact generate money for your organization on the back end. And then again, charity and self-pay management, it's effectively managed by financial counseling. They can it can really promote a reduction in AR days. I want you to all consider partnering with health plans. A lot of them offer facilitated enrollment for free. You can get patients to agree and consent to a contact form, and you just send that off to one of the managed care organizations, and they can help work with the patient to determine their eligibility through Marketplace or otherwise Medicaid applications to get them enrolled in a health plan, which generates a patient who will continue to come to your organization for services, but also is not overutilizing your ER as a primary care. They are, really filling your clinic volumes, and you're managing that patient and also getting ancillary service revenue because you helped assist in facilitating them with health insurance coverage. So that's very important. So I did it. I can't believe I did it just in time. I was really hoping I would get through all of this within the time frame to allow 15 minutes, but I really want to tell you, appropriately addressing front end in revenue cycle can really lead to multiple revenue enhancements that may not otherwise be realized. And we all work so much, and we know our patient accounting staff have difficult times getting to AR over 90 days. We know that there's a lot of back and forth that cause cash realization delays, and really building in some of these front end competencies, allowing them to not just rely on automated software that comes back. They need to understand the information that's coming back from those automated software. They need to we're moving patient access to the next level, right? They really are becoming the front end billing staff, and we need to make sure that we're investing in their education, their retention, and their skill set to allow for decreased expenses, revenue growth generation, ancillary service revenue. They're so integral to our organization's financial success. So again, happy to answer any questions, happy to provide follow-up, provide more detail to help you build some of the policies that were mentioned, anything of that nature. I want to be your lifeline. We want to see rural healthcare continue to thrive and gain strength, because really rural healthcare facility is so needed, and it is a force to be recognized and to be not to be messed with. We're going to need to keep these rural commitments to the communities that we serve, and we're going to need to do that in the most financially advantageous way possible. So with that being said, I will open it to questions, and I will turn it back over to Laura. Are there any questions that were presented in the chat? I
have not seen any come across the chat yet.
Okay. And again, as you put this out on the YouTube channel, as you mentioned, everything can definitely reach out to you folks there for Oklahoma, and they can get in contact with me. Again, on the last page of this slide, you will see that my email and my phone number is here. Never hesitate. Never hesitate to reach out. We are happy to support and provide any guidance that we can to make you rural healthcare strong.
Carrie, I actually had a question.
Sure.
We're going over the earlier slides, about when the patient first comes in, and a lot of it seems to tie back to customer service principles and onboarding. Are you aware of some really good onboarding trainings that other clinics take advantage of?
I am, and I will also, I try not to plug, but I do. I am. AHAM and NAHAM both have very great platforms out there.
Okay.
They also establish certification programs where you can get certified patient access representatives, and they focus a lot, and the components in the testing, they focus a lot on how to deliver the organization's message, customer service friendly. I prefer the Disney model. I was taught that way myself. Basically, you want your patient, the customer is always right. You want them to feel like they just walked through the gates at Disney World and won the lottery. How are you getting that? How are you communicating with them? They work specifically on just how much a smile can change. They have video trainings, et cetera. So definitely explore those. I know HFMA also has some very good patient access training videos to deliver the organization message. And beyond that, I really recommend establishing standardized scripting for your patient access staff or your reception staff to use, because you drive the delivery of the message. You know the intent that you're trying to get, and you're really scripting it so they know to utilize that scripting, and it creates consistency within your patients, mitigates some patient complaints, things of that nature. Scripting alone, I have seen reduce patient complaints and dissatisfaction scores significantly, just by making sure that the message is the same message across the board and it's being delivered with your mission statement in mind.
Thank you. Yeah, I'm going to look into those because that is actually something that I hear now quite often during site visits, both
Yes.
hospitals and clinics. And so thank
Yes.
you for that.
Absolutely, absolutely. It is, and it's actually nationwide. And I think it's, it's a combination of things. I think we're all doing more with less since the pandemic. I think that there is staff burnout. I think that some staff may feel underappreciated. So again, building in some of these competencies, but then celebrating accomplishment and having data analytics and benchmarks for staff to achieve goals really, really can lead to improved retention and improved employee job satisfaction. So it's something to definitely look into.
Thank you. Are there any other questions? Well, seeing none, thank you again, Carrie, for your time. We did record this. We will get this uploaded shortly to YouTube. If you guys have any questions or concerns at all, please don't hesitate to reach out. Our next webinar will be scheduled for July 11th. I will send out more details, including the registration link shortly. With that said, thank you all, and everyone have a great day.